The title of this presentation is Talk Back, Increasing Patient Engagement in Decision Making. I am Dr. Alejandra De Mendoza, and I am an assistant professor at the Cancer Prevention and Control Program at Georgetown University. My research focuses on developing culturally targeted interventions to reduce disparities in genetic counseling and testing uptake among underserved minority populations.
Hello, I'm Dr. Vanessa Sheppard, and I am the professor and chair of the Health, Behavior, and Policy Department at VCU, Virginia Commonwealth University. And I'm also the associate director for community outreach and engagement at VCU Massey Cancer Center. My research is focused on examining ways that we can reduce disparities for underrepresented minorities, largely and specifically minority women, African American women, African immigrant women, and Latino women.
And I'm Wanda Lucas. I'm a breast cancer survivor since 2006, and also a very active breast cancer advocate. I've participated in as a consumer reviewer for the DoD program, and I currently serve as the vice president of the board of directors for the National Breast Cancer Coalition.
We have no relevant financial relationships to disclose. And this is an overview of the talk today. We're going to be introducing disparities around genetic counseling and testing utilization and focus on some studies that show doctor-patient communication gaps. Then we will introduce a talk-back communication strategy, which was a model developed by Dr. Sheppard in her Sisters Informing Sisters study, which was the first peer-led decision support intervention for African-American breast cancer survivors. Then we will discuss and share some lessons learned from this work. And finally, we will present some of our recent work around this area. Participating in genetic counseling and testing is very important because it can provide life-saving information to inform treatment decisions and also risk management strategies. Unfortunately, there is stark disparities across all the genetic counseling and testing continuum, in that minorities have lower awareness about hereditary cancer, lower use of genetic counseling and testing, lower screening, lower referrals, they're less likely to get testing, and they're less likely also to follow the risk management strategies. And these disparities are located at different levels of analysis, and some are related to the healthcare system, some are related to psychosocial factors, but today we're focusing on some of the studies that are showing these gaps in communication between doctors and patients. The first study I want to share is a study developed by Jaxi and colleagues in 2015. And in this study, they surveyed more than 1,500 women who were diagnosed with non-metastatic breast cancer. And they showed that minority women were more likely to have unmet needs for discussion about genetic testing with a health professional. And when they talk about unmet needs of discussion, that is for women who reported a strong desire to attend genetic testing or to hear about genetic testing, but a failure from providers to discuss about genetic testing. You can see in the figure to the right that Spanish-speaking Latinas, 40% of them had unmet needs for discussion. 18% of English-speaking Latinas had unmet needs of discussion, 13% of Blacks, compared to 8% of whites. We can see another similar study that was also a large study, population-based sample of breast cancer survivors diagnosed at 50 or younger, that also based on their diagnosis, they should all have been referred to genetic counseling and testing. However, what they found was that Black women were 16 times less likely to have a discussion about genetic testing with a healthcare provider, and Spanish-speaking Latinas were 2 times less likely to have a discussion about genetic testing with a healthcare provider. And discussion about genetic testing is a key factor for utilization of counseling and testing. And lastly, in this study, the prior studies were more about barriers to referral to counseling and testing due to these communication gaps and unmet needs for discussion. But also within the genetic counseling sessions, there are important communication barriers. This is a study conducted by Galen Joseph, and in this study, they observed 170 genetic counseling visits, and the visits included patients that were English-speaking, Spanish-speaking, and Chinese-speaking. And after observing the visits, they also interviewed a subset of these patients and asked what they thought about the visit, whether they had understood the information, whether there were some questions that were not answered. And based on this information, they realized that in the genetic counseling sessions, the counselors shared too much information, that they used complex terminology, and that unintentionally they inhibit patient engagement and question asking. So even though this is not intentional, most of the visit, the counselors are talking, but there's not so much opportunity for patients to ask questions or to ask for clarifications. You can see in the table to the right, they found a mismatch between the information that genetic counselors provide and the information that patients really need or really want to know. So you can see in the left, the genetic counselors spend time talking about genetics, genes, mutations, how risk assessments are made, what is a genetic test, how is it done, potential test results, limitations of the test. Whereas patients have questions like, is my cancer hereditary? Am I going to get cancer again? Are my family members going to get cancer? What caused my cancer? And there's a mismatch in this sense. The only place where there was a match was in terms of the risk management strategies that the counselors did discuss, and this matches with the need for patients to know about how to protect themselves and their relatives. So this is another example in which we can see these gaps of communication. We know that it's really important to engage patients in decision making. And when patients have more information, have better communication with providers and better understanding, they have better health outcomes. And there have been strategies to improve engagement and doctor-patient communication, and those can be located at different levels. Some interventions are targeting the providers. They can be communication skills training. And there was a recent study that reviewed 17 studies about provider interventions around communication. And they found that while these interventions were able to improve some aspects of communication, so doctors, nurses, or other healthcare practitioners, they did use more open-ended questions, they showed more empathy. However, they also showed that there was an uncertain effect on whether after the training, the doctors were successful in eliciting patients' concerns. And there was also no difference in patient satisfaction or perceptions of communication skills. So it's important also to intervene at the patient level. And now in this presentation, we are going to be talking about an intervention, Sisters Informing Sisters, developed by Dr. Sheppard, and the talkback communication strategy.
Sure. So one of the important points, just thinking about our audience today, is that the talkback model and Sisters Informing Sisters was co-created with survivors. It was co-created with input from providers that saw large numbers of African-American women, as well as, and providers included both physicians and nurses, and advocates as well. And so while I was probably the catalyst that brought it together, this really was co-developed in collaboration with the community. And so the talkback model is nested within the Sisters Informing Sisters project. And the idea was really wanting to figure out how can we enhance the encounters that women have. If you think about the key way that information is translated once you're diagnosed, it's in that encounter, quite often with your medical oncologist. Other team members and medical team members are often apart. Family members are sometimes apart, but we really examine, what could we do to help really empower and inform women to make relevant decisions. And so central to the Sisters Informing Sisters intervention, which includes culturally relevant materials that were developed. In fact, it was around the table that this issue, this idea of talk back came about from a focus group. It includes a trained survivor interventionist, and we were specific about wanting a survivor to be the interventionist. And again, this came from qualitative interviews and focus groups that we did within the community to identify how could we best sort of model this idea of optimal communication. And then we developed communication materials and materials to support the decision. So the communication and the decision making really kind of go together within this model. And so the first part of the talk back model is to tell your story. And with regard to the story is wanting patients, and again, this focused on African American women, to be able to tell their story, who they are, their preferences, what their values are, so that their medical provider would know this information and be able to consider how would this information impact a person being able to follow the recommended guidelines or not, and who else may be important for them to consider in their experiences of treatment. The next level was to ask questions. And we know that's very important. And we wanted women to have the skills in asking questions. And so they were actually trained in different techniques in terms of both telling their story, perhaps maybe how to interrupt the physician that's talking, to ask questions. And then they went through with their survivor coach, going through the process of identifying questions that were relevant for them. And we did help them by having common questions pulled together that many survivors will often want to ask. And then the next was to listen actively. And I know many of us have had an experience where we're in an encounter, we hear, we walk away, and it's like, what was just said, right? And so just realizing when communication is taking place in a very stressful environment, a lot of technical information, a stressful situation. And so we wanted to, again, have women develop and practice skills in terms of how do you listen actively and taking notes and engaging. And then the last piece of knowing your options, this was a process. And so this model include having women to be familiar with what the treatment options may be and walking them through a process of weighing the benefits and the costs of a particular treatment option. Now, when I talk about sort of the benefits and the costs, this isn't just from a numeric standpoint and just from, the clinical perspective. This is, I'm going to maybe make this decision, and as a result, I may have to tell my family. So thinking about, again, the audience today, we think that this is something that can be relevant in multiple contextual environments, because what we do as individuals, as women, we know it impacts a lot of other people. So that's a overview of sort of talk back, telling your story, asking questions, listen actively, and then knowing options. I'm going to hand this off now to, our extraordinary survivor coach. And so I mentioned earlier that we have trained survivor coaches that implement. And so Ms. Wanda Lucas could really give you the perspective of sitting in front of patients and sitting in front of survivors and implementing this model.
Thank you. So I love the talkback model. I want to make sure everybody knows that. I think it's very empowering for women. And as women in the audience, I know you recognize, or you should acknowledge, that we try to take care of the whole world. And I think the talkback model allows us to take care of ourselves. So I wanted to give you a perspective of how it would look like in the real world, if you will. So when Dr. Sheppard mentioned telling your story, like who you are and what your values are, I try to give women that I've worked with in the past a real example. First of all, one thing I want you to remember is that you make decisions every day. You made a decision about what you wore today, what shoes you put on, a route you took. So you make decisions all the time, and making decisions around your healthcare involves some of the same task, if you will, or some of the same actions. So when you start telling your story, it could be something like the woman I work with who wanted to have as normal a life as possible while going through treatment for breast cancer. And one thing that was very important to her was singing in the church choir. So I talked to her about that, and she talked about the joy in doing that and being a servant, if you will. And what she was concerned about was missing rehearsal. So when I was getting her ready for her appointment with the healthcare team, I had to remind her that that's something she should share with the healthcare team. My rehearsal is on Tuesday. So if I'm going to have to take chemotherapy, I want to be well enough to make choir rehearsal on Tuesday. So maybe my chemo treatment should take place on Wednesday. And then by Sunday, I will feel well enough to sing in the choir, and that will bring me joy. Dr. Sheppard also mentioned asking questions. We work with women to ask the questions that they want to know about, but also we also give them frameworks to make sure they ask the questions that they should know. So there are questions that you want to know, and there are also questions you should ask to make sure you get all the information you should know about your diagnosis, about the treatment and the impact on it, when you have to make the decision, what's involved, those kinds of things. So asking questions, and my one thing I always stress is that they should be written down. And I remember being in that situation myself. I had pages and pages of questions because I had a page for each provider. But what I learned is they appreciated that. Dr. Sheppard also mentioned the importance of listening actively. You shouldn't expect to remember everything that's said to you. There's a lot of medical jargon. There's a lot. You're going through all kinds of emotions. So we encourage you to take notes, but also it's also appropriate to ask the provider if you could record the visit. The other thing that I suggest, because I worked with a lot of African-American women, we bring our whole village with us. So bring somebody with you to the appointment, because they tend to hear the things we don't hear because we're experiencing things or not. So it's okay to bring someone with you, to have them in the room with you when you're asking those questions and when you're getting the answers. And then the final step is knowing your options. Again, you make decisions every day. You probably talk to several people when you bought your house or moved where you live now, or decided on a career. You looked at different things, you consider different perspectives. So we want to make sure through this model that you know your options. Again, it could be the timing of a certain kind of treatment. It could be a kind of treatment. It could be where treatment takes place. It could be who's involved. All those things, you want to know your options, because this is your life, your decision, and there's nothing better than a well-informed decision. Like, you wouldn't choose what to put on the day if you didn't know where you were going or what you had to put on. Or what you were going to do that day. So that's informing you on the decision you have to make. So the talkback method is amazing. It works, it's empowering, and it was created for us.
So I'm going to just highlight some of the things that we learned. And this was a single arm trial focused on African-American survivors. And what we found after the intervention, and again, these were women making treatment decisions, that the majority of women reported higher levels of self-efficacy. So their comfort and confidence in their ability to communicate with their providers, as well as higher self-efficacy in making treatment decisions. We compared scores at baseline and post-intervention, and we found that communication with providers significantly increased. Right now, we have, from what we've learned from this study, we are now doing a larger randomized trial focused on 400 African-American women that we hope to recruit over the next 5 years, where we will be testing the CIS intervention with enhanced care. And the enhanced care piece are, again, based on things that we learned, and I'll just kind of piggyback to Wanda. One of the things that Ms. Lucas shared, that was very important that women understand their pathology reports. Because again, we want to, I guess, level the playing field, if you would, in that encounter, so that women have the language and understand the jargon that's sometimes used to be able to engage in those encounters. And so now we're going to talk about lessons learned. What have we learned, Dr. De Mendoza?
We've learned a lot. I was reflecting of some of the things learned throughout these years in conducted research and developing interventions with Latina women and African-American women. And one of the most important things after interviewing a lot of women and hearing their stories is that all of these women should have been referred to counseling, should have been referred to testing, should have had appropriate care. And oftentimes when they come to the studies, it is the first time that they are hearing about hereditary cancer. It is the first time they're hearing about genetic counseling and testing. And for some of these women, it has been too late. And it's been to the point that they got a second cancer, they got diagnosed with ovarian cancer. And I think this is just unacceptable. So I think that it's something we need to do to empower women to ask those questions. We have seen like all these disparities and how the discussion is not taking place, how minority women are less likely to be referred, less likely to have discussions. And I think the talkback model could be a great way for women to be empowered and to be asking those questions. This is my family story. Am I at risk? Should I be seen as a specialist? Like, what should I do next? And also to know that they have options throughout all the continuum. Like, going to counseling doesn't mean you have to do testing. There's different management strategies. So just the awareness and the empowerment and the knowledge and the empowerment to be asking those important questions. So even though this model wasn't applied to counseling and testing, I think it could be a great model to apply in this setting too.
So I think that's such a good point. So one of the things for me, I think that I've just learned is that the teams are so important. And I think as researchers and as scientists, we have to have the humility to listen to our participants. And things may change from what we thought. I think that making sure that we have diversity in our research studies is very important, and that our teams are diverse. And so, I tease Ms. Lucas all the time because we met because she was in one of my studies, but it's really changed in many ways. It's changed my research life. It's changed my personal life too, but it's changed my research life because she had an opinion. She asked questions, right, about the research process, and it improved as a result. And then we went on to then, she became engaged in research. So I think that that's important, that scientists, that we have that humility. And then we think about who do we have on our teams? Because when I think about sort of this talk back model, I think that it has the components of patient-centered care. And I think this was also important. There may be elements that once you have a diagnosis or once you're making a decision about counseling testing, how can you then apply that in your own circle, in your own village, in terms of when you have to have communication. And so I think it's patient-centered or survivor-centered or person-centered, but it's really in mind that for many of our communities that are from underrepresented minority groups, they really make decisions or take into account all those people around them. So I'm going to pass the microphone to Ms. Lucas to say lessons learned.
I would say the greatest lesson is that through the talkback model and the CIS program, I think women, again, I felt empowered. I've watched people sit up straighter, and as a result of the intervention, they enter an appointment with the healthcare team, knowing it's about them, and they know that they have the right to get those answers, and they also have the right, as Dr. Sheppard mentioned, to be heard. So I think it's very empowering, because if a woman doesn't understand some jargon, they can say, I'm not clear on what that means. So I think this talkback model is very, very important and very effective, because there are lots of researchers and healthcare providers that do listen. So I want the people in the audience to know that your voice does matter. And it's really important for you to speak up and ask what you don't know, and ask for those answers you feel you deserve. You're the customer. So.
Now we want to share some of the exciting current work that we are doing around this area. So we have currently two projects. One is Rosa's Story, and the other one is for our health study. So Rosa's Story, it's a culturally targeted telenovela video. And as Dr. Sheppard was mentioning, it took us 2 years to develop, because we did a lot of interviews with women, with providers. We wanted to know like what women knew, what they didn't know, what were their needs, like what were their values around the decisions to participate in counseling and testing. So it took us 2 years just to understand that. And then we partnered with the National Conservatory of Dramatic Arts, because we wanted to make this a story instead of just providing medical information. So this video, it's an 18-minute video and tells the story of Rosa, who is a breast cancer survivor, and it's all the process when she learned about hereditary cancer and then overcome the barriers as she attends counseling. And then it's all the story about the family and the communication and the support. And it also models some of the pieces of doctor-patient communication to show, how to ask those important questions. So we are now in the process. We did a small pilot study that had promising findings in improving knowledge and use of counseling. And now we are testing this video on a larger trial with 300 women. So Dr. Sheppard, do you want to?
Sure. So the 4-Hour Health study is a pilot project that builds on a lot of qualitative and survey data that we collected from physicians, African-American women who were at increased risk of hereditary breast or ovarian cancer, from survivors. And we saw some of the gaps that Dr. De Mendoza mentioned earlier. And so this video has been developed during COVID. And so we used a very different format than some of the prior work that we did before. And so we're right at the stage now where we are starting to recruit to test really the efficacy, of this video. Does it increase knowledge? Do people like it? Particularly given this format. So we're in that phase right now where we're in the field with that. And we are partnering with Force for this video, and they were also members of Force, helped to inform some of the early stages of this video development. And so partnerships with community organizations and professional groups are very important for our work.
Yes, and we are excited to share the findings back, hopefully soon.
Hopefully.
The next
meeting. Yes.
So we'd like to thank all the audience, and here's our contact information in case you want to email us.
Thank you for your time.
Thank you.
Yes, thank you.